So you all can see, right? The fundamentals of pathophysiology. Yeah, the chapters may not reflect the content, but don't go by the chapter the numbers, um, because we have cell biology, which is chapter 1, and then the genes. Let me just go over the weekly outline. The weekly outline, we have the cell biology, which is chapter 1 and 2 is the genetics, and then 4 is the altered cell biology, and the number 5 or chapter 5 is the fluid electrolyte acids and bases. So this will be our content for this week. Chapter, and as you know, on the syllabus or the weekly outline, you will find that the numbers in like italics, which is usually the first chapter of the system. It's either structure and function of the system, or the first one, like chapter number 1, which is the cell biology. These chapters written in italics, these are independent kind of study. That's because that's in pure anatomy and physiology. And this is a pathophysiology class which builds on the concepts or the foundation of the EMP. So you need to know to be competent EMP and have a sound knowledge in order to be able to understand the pathophysiology, which is a disease process. So EMP provide you with the norm, like what's the normal anatomy and physiology. And now we are, studying the disease, which is the alterations from the norm. Changes, alterations, pathophysiological changes, disease process. It's all pathophysiological processes and changes and the disease process. So some of the slides you already know about, these. So I tried to incorporate some content from other resources to give you like, foundation to start, because now we will start a different language. Now this is a pathophysiology language. Some of these will say like, the onset of disease, for example, when the symptoms or manifestations, when you say manifestations, it's like signs and symptoms. When the symptoms or manifestations starts or began or have started, that is something called onset of the disease process. Prognosis is another concept or terminology in pathophysiology. When you say idiopathic, right, when there is no etiology or it's unknown etiology. Etiology means what has caused this disease. What are the risk factors that have resulted in this specific disease? So which means the etiology, causes of the disease. When there is no etiology or etiology is unknown, we call that idiopathic. So these are some of the terminologies you start to kind of, be acquainted and try to be familiarized with them, because you will be using them a lot, and that will be your kind of new language as you discuss the disease process and the disease and treatment of these diseases. Another factor, we refer to it as refractory, from refraction, like refractory to means that the treatment is not effective, isn't effective, that it is not responsive to the treatment, called refractory. I believe that most of that, these slides, covered in anatomy and physiology. If not, you can just review them, because this is all terminology, and you need to be just, be familiar with, and them, like diagnoses. What is diagnosis? That when you identify the specific disease, we call that diagnosis. Like when you do an X-ray, an ultrasound, testing, blood test, in order to diagnose, a disease. therapy, prognoses, homeostasis, and I'm sure you went over this in different courses. The pathogenesis, which means the disease or the the pathogenesis, which is the development of the disease, which called disease pathogenesis. So the most of the diseases, especially when it comes to the endocrine system, you'll find that all, and this applies to almost all systems, that the diseases are either they are over-functioning, which is hyper-functioning, or under-functioning, which is hypofunction. Take an example of GI system. When it's not functioning, EU means normal, EU function, or EU like thyroid gland. When the thyroid gland is hyper-functioning, we say that patient has a hyperthyroidism. Patient whose thyroid gland is not working enough or sufficiently producing enough hormones, we say that it's a hypothyroidism. When it's normal, like healthy, no disease, we call it euthyroid. Euthyroid, EU, and then thyroid, euthyroid. That's normal functioning. So apply this to the GI tract. Hypo in the GI tract or the GI system is not hypofunctioning, so it is like when we experience constipation. Like in your physical assessment course, you went over what changes in the as you listen to the bowel movement, or I'm sorry, bowel sounds. What would you hear as bowel sounds? Either it's hypo, right, or hyper. So when it's hypo, which means that patient could be constipated. When it's hyperfunctioning, which means
like diarrhea.
Diarrhea. It's due to the increased mucus production, which is, in other words, that we are looking at the secretions over production. So mucus production could be increased. That's why there is an hyperfunctioning. Hyperfunctioning because of decreased peristalsis. That's why patient is constipated. Or an increased mechanical function, like electrical conduction or the impulses and in the brain cells. There is an overproduction or over mechanical function. So that's when the patient is going to experience the seizure attacks. In other words, we call it convulsions. So these are the stages. It doesn't apply to all diseases, but the stage of disease progression starts from the exposure or injury. Either you're exposed to the, let's say, like microorganism, or an injury has resulted from like a traumatic injury. And there is some diseases, like infectious diseases, they have like incubation period or latency period. We have prodromal and then acute, but then remission, convalescence, then recovery. So it doesn't mean that all diseases all should follow this specific format, but most of the diseases they do. That there is some diseases, we call them remission exacerbation. Anyone knows what the difference between remission and exacerbation?
Remission is when it occurs, exacerbation is to become worse.
Right. Yeah. So it's exacerbation. And this is when exacerbation. That's when the signs and symptoms, when they are heightened, like the highest intensity of the signs and symptoms, that's when the patient lives in exacerbation. Some of the chronic diseases, we'll go over some of these diseases, like in neurologic system or in the cardiac or in the endocrine, the patients, they live at some point, you'll find them like in their best of their health, and then at some point they are admitted in the hospital with exacerbation, like COPD, for example, patients with chronic obstructive pulmonary disease, asthma, especially COPD more than asthma. They have remission phases in which that the symptoms and signs and symptoms are very a lower base, or they are very limited, or at some point they're absent. We call it remission phase. At some point they call it flare-ups, like exacerbation. When exacerbate means it's the signs, symptoms, manifestations that are heightened, and they are, they are evident and heightened, and very easy can find, you see them, and the patient experiencing them to a heightened and high extent. And at that point, in most of these diseases, this patient, when they have, or when they are experiencing exacerbation of the disease, they will be admitted to the hospital. These are some of the cell physiology and the functions of the cells. Specific, this is AMP, epithelial connective, nerve cells, muscle cells, and the abnormalities of the cells, which could result from physiologic, or it could be pathologic. So one of the tissue alterations of the tissue structure is that the tissue becomes smaller. In which scenarios you think that the cell becomes smaller than normal, when others will shrink or decrease in size?
Could that be old age?
To some extent, yes, but what would be, yeah, okay, so what would be more prominent, like very prominently, you can see this very easy?
In the healing process after like infection, the cell is trying to kill itself, like making it smaller. And
No, let's say from your observations.
Is it like stress when you are stressed?
The muscle becomes small. Have you seen people with paraplegia?
Okay.
Who are paraplegic, or with a CVA and have limited movement of the arm and leg, like severe brain attack or stroke?
Yeah.
Patients with paraplegia or quadriplegic. So there will be an atrophy of the cell. So the atrophy, we call it atrophy, when the cell atrophied or the muscle atrophied. So here with the atrophy, that the cell size becomes smaller, and these are the reasons why the cell becomes smaller. So it gets smaller in size because either because of the decreased use, decreased blood supply, insufficient or decreased nutrition, decreased hormone or nerve stimulation.
Decrease blood pressure, decrease.
Yeah. So aging, that could result in brain cells and gonads to shrink to some extent, but mostly the disuse atrophy that would result from like neurologic, like a stroke, paraplegia, and so forth. Now, other type of alterations to the cells would be to increase in size. The cell size would increase. We call that hypertrophy, because of the increased workload, because of the increase in hormonal stimulation, because so this kind of, and sometimes it is due to the hypertrophy as a compensation process, compensatory kind of mechanism to compensate for the function. Examples of that, and provided here lots of examples of, like, first of all, we have three types. So the hypertrophy can be physiologic or pathologic or compensatory. So the physiologic, like hard physical, physical labor or weight training or enlargement of the uterus and mammary glands in response to the pregnancy, all of these are physiologic. When we hear the word physiologic, which means healthy, that's normal. It doesn't mean it's pathologic or it's disease or related but when the hypertrophy it's pathologic, then that's, for example, for when the heart muscles is becoming thick, the wall of the thickening of the wall of the cardiac muscle becomes thick, and that is pathologic. It's no longer as physiologic and normal, and it has to be treated, because that would result in the decrease in the function of the cardiac as a pump. So that's an example of pathologic. We have another for alteration of when the cell becomes hyperplastic, which is hyperplasia. And an example of that, it's not here the size of the cell become larger or bigger. Now it's the cell number will increase. So this is a difference between hypertrophy and hyperplasia. Hypertrophy, the size of the cell becomes bigger, and the hyperplasia, the number of the cells will increase. And one example of this is the BPH is an example of that. Benign prostate hyperplasia. In the past, outdated now, it used to be hypertrophy, but the pathophysiology science kind of found that it's not the size of the cells becomes bigger in the prostate hyperplasia. So it's no longer hypertrophy, it's hyperplasia. They found that it's not the size of the cell, it is the number of the cells becomes bigger. And the BPH gives the significance of hyperplasia. It's little, I would say, more serious than the hypertrophy. Like patients with a PPH, at some point they may develop the prostate cancer. So they have to do what is called the PSA test, prostate specific antigen, to rule out or to make sure that they have, that level is not too high, so they will be at high risk to develop the prostate cancer. So the BPH, an example of that, it's no longer is called hypertrophy, it's a hyperplasia. It's not the size of the cell has increased, it's the number of the cells has increased. Another form of hyperplasia is that when given the increased number of the cells, which is due to the increased division of the cell division, has accelerated. An example of that also, it can be gingival hyperplasia in response to the treatment of certain medications. Does anyone know which medication would result in gingival hyperplasia as a side effect?
Is that a question, Professor?
Yeah. Which medication would result in hyperplasia as a side effect of taking that medication?
I know Dilantin is one.
Right. So Dilantin, phenytoin is the drug that causes which is given for?
It's given for seizures.
Right. So you give phenytoin, Dilantin. So what would I include two names here? What should I include two names? Phenytoin and Dilantin.
One is the component, and the other one is the like
Trade name
the
and-
trade name. Yeah.
Generic, yeah.
Generic.
So phenytoin is generic name. You'll learn about this in Forum next fall. But this one is the generic name, which is like, you couldn't call it like scientific name. But the Dilantin is the brand name. This is the name the company gives the brand name, the generic name, sir. So generic name stays, whenever you go for that specific drug is going to be phenytoin as generic name. But companies, they give this generic name different names called brand name. Dilantin. Other company would call it, different than Dilantin. But the generic name should be the same. So Dilantin, phenytoin Dilantin is just to orient you to the, in the future, if I, put or include or, write two names, that will be generic name, and in parentheses, the brand name. So this is a anti-seizure medication used to treat seizures and convulsions or seizure attacks. So one of the side effects is gingival hyperplasia. This is one of the adverse effects of the drug, is that will increase the thickness of the gingiva or gingival hyperplasia, which is the increased number of the cells of the gingival cells, and that's one of the complications. So it's, in this case, it will be a pathologic. It's abnormal. It's pathologic. We have physiologic. We have examples of the pathologic, like the monthly increase in the uterine cells due to the estrogen stimulation after ovulation, which is the hormonal hyperplasia. That's normal. And then we have compensatory, which is a compensation process, which is when the liver cells regenerate as part of the, let's say that patients experiencing liver cancer, and then part of the liver should be removed. So they have to excise and dissect part of the liver. So then the remaining part is going to regenerate, and this is called compensatory. So it's like compensation and compensating for the loss of the part. And other examples here too. Pathologic, I provide just an example of pathologic, which is in response to the treatment of Dilantin, that patient could develop the gingival hyperplasia, or the pathologic endometrial hyperplasia, the imbalance between like estrogen, progesterone secretion, especially in the postmenopausal phase. Now the dysplasia, which is the abnormal differentiation of dividing cells, causes abnormal cell shape, size, shape. So it's the size, shape, and appearance. The new cell from the cell division will be different in terms of size, shape, and appearance. I'm not sure I have an echo. Is that just me, the echo, or everyone?
Yeah, I also hear the echo. Somebody has to mute themselves.
Is everyone is muted, or? Yeah, I didn't have this problem this morning. Yeah, try to just mute unless if you have a question, please. So the dysplasia, we said that the new dividing cell, or the parent cell now, or the resulted from the cell division, now it's different in terms of size, shape, and appearance. And the dysplasia only occurs in mature cells only. At this point, the dysplasia, it's reversible. It's not like permanent, and that's going to result in a permanently abnormal cell. It can reverse itself and go back, to be normal. An example of that is dysplasia of the cervix or the respiratory tract. And what they found is that the dysplasia, or we call it dysplastic cells, they are adjacent to cancerous cells. when they do the pathology and when they do the dissection of biopsies, they found that the dysplastic cells, they're always next to, they're adjacent to the cancerous cells. In other words, that the dysplastic cells could convert and become cancerous. Now, the last one is called metaplasia. This one is immature cell. The difference between dysplasia and metaplasia, dysplasia is, the cell is mature, and metaplasia, the cell is immature. In other words, it's less differentiated cell type. It will result in replacement of one mature cell type by another, but sometimes this differentiated cell will also be. So that's the dysplasia and metaplasia. They're very, there are similarities between them. And at some point, it's very difficult to differentiate until you do the pathology, and you'll find the difference. So the metaplasia, it's more dangerous to be cancerous than dysplasia. Metaplasia. So it's metaplasia, it's very easy to become neoplastic cell. Neoplastic. Dysplasia, this is likelihood too. But metaplasia, it's more likely than the dysplasia. So we have metaplasia. The new cell can endure the stress of chronic inflammation. We have examples of this one, like cigarette smoking. It will cause replacement of normal ciliated epithelial cells of the bronchial tree or a bronchial lining. It will be replaced by stratified squamous epithelial cells. And these new cells, so this is the replacement. This is kind of cells be replaced with new cells. These cells in the bronchial lining do not secrete mucus or have cilia, which is the protective mechanism, as recall this from EMP. The mucus secretions and the bronchial tree or bronchial lining, the presence of the cilia, all protective mechanisms in the respiratory system. So this is one of the changes in response to the cigarette smoking or exposure to tobacco. So it's either physiologic or pathologic. Now, the cell degeneration, the cell, which is the cell death of the cell, could result in, due to the swelling, swelling of the cell, could be due to the infiltration in the cell, like fatty infiltration, due to atrophy, autophagocytosis, pigmentation changes, calcifications. All these are responses or causes for the cell degeneration. And it can be reversible and irreversible. And this is like the step before the cell death, cell degeneration. Here, talk about the cell injury and the sources and the causes of the injury. Can be intrinsic, can be extrinsic, like infections or trauma or deficiency, like hypoxia and hypoxemia, ischemia. So what we have two different terms here, ischemia or hypoxia and hypoxemia. So we have hypoxia, and then we have hypoxemia. So which one precedes or comes first? Is it the hypoxia or hypoxemia?
Hypoxemia, because I think that's where exchange of oxygen occur.
Right, hypoxemia which is the percentage or amount or adequacy of oxygen or oxygen supply in the blood. If there is insufficient or inadequate amount of oxygen in the blood, that is not going to supply the tissues. So hypoxemia will precede the hypoxia, because hypoxia is the inadequate oxygen supply to the cell or the tissue. So the cell is not receiving enough oxygen because it's either the blood doesn't have enough, patient is anemic, decreased hemoglobin, right? Or because the patient has an airway obstruction or COPD or asthma, and there is decreased oxygen either in the air or patient's inability to have the oxygen or air gets into the lungs due to that obstruction or changes or alterations in the lungs, asthma, COPD, bronchiectasis, emphysema. All of these are changes within the structure of the lungs that prevents the air or oxygen to get into the lungs normally and do the exchange of gases. Or there is insufficient number of oxygen in the blood due to the, which is an anemia due to the, because the hemoglobin holds the oxygen and carry the oxygen. Patients hemoglobin of 6.5, definitely they will have, other than the weakness and right and fatigue, and also they will have respiratory oxygenation problem. In other words, to the tissues will not have enough oxygen reaching them, so that's would result in adequate in hypoxia. Obstruction within the blood vessels, like thrombosis, blood clot, arteriosclerosis, which is the sclerosis of the arteries, which becomes the stiffness of the arteries. What's the difference between the arteriosclerosis and atherosclerosis? Atherosclerosis and arteriosclerosis. Any difference?
One is like the fat in the blood vessel. The other one is like a thickening of the walls of the arteries.
Yeah, the arteriosclerosis is the sclerosis of the wall of the arteries. So it's the stiffness. But the atherosclerosis, I mean, they are vice, the atherosclerosis could result in arteriosclerosis. Because the atherosclerosis is the atheroma, is the plaque formation, lipid deposits in the arteries, which make it, the lumen is becomes smaller because it's in the pathway, in the passage of the artery, and also the lining, because that's the position on the lining of the wall of the artery. So it becomes also sclerotic as well, stiff. So the atherosclerosis could result also in arteriosclerosis, which is the stiffness of the wall of the arteries. Thrombosis, which is the blood clot. DVT, deep vein thrombosis, cerebrovascular accident, acute myocardial infarction, all would result in hypoxia to that respective tissue or organ. Why would a patient with acute myocardial infarction experience severe chest pain? What would be the source of that chest pain? What's the reason they have that severe chest pain in the acute myocardial infarction?
I think the muscles
The lack of
to pump the blood.
lack
Shital,
of
go.
oxygen.
One at a time, please. Shital, go ahead.
Okay, so I think it's when your muscles are really trying hard to pump the blood, and then it just get fatigued.
Okay. Thank you. Who else?
Does the pain come from the death of the tissue in the heart?
Donna.
Yes.
Okay. One more time, please, Donna.
Does the pain come from the death of the tissue, of the heart tissue?
Okay. Yeah, you are very close. It's not the death of the tissue yet. It's more of the, what would you call that?
The cell.
Ischemia.
Ischemia.
This is another term, to today to learn, which is called ischemia, ischemic changes.
Ischemic changes.
So
Is it
ischemia
lack
would
of
be
oxygen to the
right insufficient of. It's another. Let's this first spell it first. ISCHEMIA, ischemia. So when we say ischemia or ischemic changes, it's another explanation of the hypoxia, or another term to replace hypoxia. It's very similar to that. Hypoxia means inadequate oxygenation to the cell or tissue. The ischemia, it's not just the oxygen, it's the blood supply. In other words, that it's the blood supply, which includes oxygen, RBCs, white blood cells, and nutrients and everything. Let's just think of hypoxia and ischemia. Hypoxia more concerned with oxygen, but the ischemia, it's everything, blood supply, including the oxygen. Yes.
So the ischemia, is it more like low oxygen in the red blood cell, or is a combination of everything?
No, when you say ischemia, always, so hypoxia, always think about or think of the oxygen supply. Ischemia, right away think of the blood supply. How is that?
Okay, that makes
Ischemia, blood supply. Hypoxia, oxygen supply.
okay.
Just oxygen, hypoxia. So the ischemia, it's more broad than hypoxia, because ischemia, which means blood supply to the tissue or organ. So which means, anyways, the ischemia means inadequate, always insufficient amount of blood supply, always.
So hypoxia is more at like lungs level?
No, at cell level too, which means that when the tissue is ischemic, definitely it's hypoxic.
Okay.
So again, ischemia, it's broader than hypoxia. So anytime there is, any organ or tissue or cell is ischemic, definitely it's hypoxic too, right? Because ischemia, blood supply, blood includes oxygen. That's at the cell level, right? So you can apply this as cell, because we have two different levels. We have cell level and we have pulmonary level, respiratory too. So sorry. Any other questions before I go forward or keep going? Hypoxia. Yeah, these are just examples of of tissue injury and chemical injuries, and what makes would result in trauma to the cell and injury to the cell. Examples of also of the infiltrations to the cell, like water and electrolyte. Example of this one would be the failure of the sodium potassium pump, would result in a depletion of the ATP, which is the source of energy, which is the at the cell level. This is at cell level, which is the adenosine triphosphate, ADP depletion, and then it will result in failure of metabolism, failure of the sodium potassium pump at the cell level. Then the water and ions will gush into the cell, would result in swelling of the cell, which is then eventually swelling of the cell could result in death. And the swelling of the cell is called oncosis, the fluid inside the cell. Due to that, depletion of the ATP as a source of energy, failure of the sodium potassium pump, and then eventually the water and ion will gush and enter the cell. That's an example of the cell accumulation or infiltrations. Other examples would be changes in the joints, in the cornea, and on the liver, spleen, glycogen storage disease, like in diabetes mellitus, patients who are diabetic, they have a glycogen problem with the glucose metabolism and glycogen storage. The pigment patients, an example of that would be patients who receive, like here we have hemosiderin and hemosiderosis. Yeah, the hemosiderosis, it's the byproduct from the blood transfusions. Patients with the blood, receiving frequent blood transfusions, like severe anemia, let's say like thalassemia, which requires that the patient should receive frequent blood transfusions, sometimes on a weekly basis. I don't know what this thalassemia is. Thalassemia.
I have the carrier gene for it.
Oh, who's that? I'm sorry.
Andriana.
So that's yeah, the thalassemia from thalassa, which is thalassa means Greek language. Greek, in Greek, thalassa means sea. Thalassemia. So it's the anemia of the Mediterranean Sea. So countries around the Mediterranean, I would say chain, Italy, Greece, Middle East kind of countries, and they are around that sea. They have that trait, and still we have in the U.S. we have about not more than maybe 2,000 cases. Back in the 80s, I wanted to do a research study on them. I couldn't find enough. We were like around maybe 1,000 cases. I mean, because thalassemia major, not thalassemia minor. Yeah, Andriana could be like the carrier for the gene, right? But not not presented or have any signs and symptoms of thalassemia, right?
Yeah.
It's just carrier for the gene. So it's recessive means that your partner is supposed to be tested for thalassemia. If both are having both have the alleles or the genes, then it's a problem. The offspring could have a minor or major. It depends on the analysis of genetic testing. So the like in the middle, some countries they have only some of the countries in which they have high prevalence of thalassemia cases, they will not approve even the marriage when they both partners they have they have to be tested anyways before they get to the approval. If they have controlled kind of on the contract and so forth, but they have to they are obligated to to test for the thalassemia, to be screened, in terms of genetic testing. And if they have the trait, then that's a problem. So the thalassemia major, it's a very difficult disease in terms of that the patient will experience some cases blood transfusion on a weekly basis. Imagine every week the patient should go for blood transfusion, in addition to other delayed developmental stage and and things that associated with the disease process. But just an example, I just brought this example of thalassemia because it requires the frequent blood transfusions, and then from receiving all of these blood transfusions, the patient will receive also the iron. The iron is part of that. So they will develop something called hemosiderosis and hemochromatosis. In other words, that the excess of the iron is going to be how would the patient develop the excess of the iron as deposition in the liver and the spleen and under the skin and the sclera. So how would the patient would develop or get these excess of iron? What would be the source of the iron? Frequent blood transfusions means patients receiving lots of RBCs. Lots of RBCs supposed to be destroyed. So the destruction of the RBCs would result in something called, the iron, which is the byproduct, heme, globin, So the heme, part of it is the iron. So the iron is going to be presented here as an excess, and the patient will, all that excess of the iron is supposed to go somewhere, either deposition in the liver and the spleen and under the skin. So this is what is called the hemosiderosis, means the deposition of the iron in the tissues or in the organs and under the skin. And one of the treatments for that, and that's also another term to know, at some point we have to give patients drugs and medications to counteract the accumulation of the chemical product of the drug or byproduct, like in this case, the iron. We don't want the patient to develop lots of, anyways, we have to continue giving them the blood transfusions, but we cannot, but we have to treat the iron excess. So that accumulation of iron has to be treated. And we can give them medication to counteract the deposition of the iron, and something called chelate. So this applies also for this scenario, but if I repeat it somewhere else in other systems, it's called chelating agent, CHEALATING, chelating agent. Like in this case will be like Desferal. It's a medication anyways, but you don't have to know it, or at least just I can give the pronunciation for it. DESFERAL, Desferal. And this is a medication belong to a group called chelating agents, CHEALATING, chelating agents. In other words, that it will counteract the accumulation of the iron, this Desferal medication, and the patient will keep receiving the blood transfusion without having the danger of these hemosiderosis or hemochromatosis. So it's just from the excess of the iron.
Professor?
Yes.
Are chelating agents only for metals in the body, or are they for other minerals?
No, it will be for also other minerals too. Yeah, because we will go over this in other systems. Yeah. So cell death, we have two different types of cell death. The normal cell death, that the cell will reach some point or some age or certain number of days and it will die normally, which is called a programmed cell death. And the terminal scientific term for that will be the apoptosis. So the programmed cell death, that's the natural. Yeah, not this one, just on here because I don't want to go back to the blackboard and and write it. I'll write it here. It's called apoptosis. This is the natural programmed cell death. Each cell keep dividing, which is the cell division, until it gets to a certain age and day and or time, it will die. So that's the natural normal cell death. We call it programmed cell death. The scientific term is called apoptosis. And they link the cell. So let's talk about the cell death in response to other causes or reasons. Like we have when you say necrosis, necrotic tissue, right? You heard about necrotic tissue necrosis, right? So necrosis means necrotic tissue means that that's a dead cell. I've seen this like in a big toe or like patient who's diabetic wound and they resulted in or gangrenous, and then the gangrenous gangrenes or gangrenous tissue becomes, that's necrosis. That's a cell death, has to be removed. So there's no way, it's irreversible. So this is not programmed. This is different than programmed cell death or apoptosis. So this is cell death resulted in response to other factors. We have different forms of forms of the necrosis. and you can review them. Coagulative necrosis, liquid facultative necrosis, and we have caseous necrosis, and we have examples of that. And then we have fat necrosis, gangrenous necrosis. All of these are different different types of cell death in response to different factors, mostly traumatic, microorganisms, disease process, and chemicals, and traumatic agents. But here we have a cell death that is normal, natural, programmed, genetically programmed cell death, which is called apoptosis. The apoptosis, it's one of the not new sciences, but one of the cutting edge science now. They are looking at the telomere, because they're trying to associate the telomere or telomerase, which is part of the DNA, or the last part of the chromosome, I'm sorry, of the DNA, and they link that the length of the telomere. I don't think I have a good picture of that. It's the last section or segment of the DNA, and what they say that with each cell division, the telomere, which is the last segment of the DNA, becomes like short, smaller. So every cell division becomes smaller and smaller until the last division, when the telomere is gone, because of the telomerase enzyme is not there or will be absent, then the cell will eventually die, which will bring it to what is called the apoptosis. So the natural programmed genetically cell death is linked to what is called the last segment of the DNA, which is called the telomere, in response to the presence of the telomerase enzyme. So the telomerase enzyme gets insufficient, result in smaller cell, telomere with each cell division. Then eventually, when it's gone, then the cell will die. So that's apoptosis. And now they are trying to, some of the cutting edge kind of scientific, research studies, they're trying to link this to life expectancy. And I'm not sure how far they get with this kind of research and find out, how long you can live, and life expectancy is linked, because, we can study genetically, you can study the DNA for that, specific, person. You can predict, life, or, life expectancy for that, based on this type of science. But just to give you an idea about the apoptosis as a term we use to reflect the genetically natural cell death.
Professor,
So yes.
I think they're doing that at Berkeley, and I think they're also working on ways to encourage cells to hasten this process for cancer cells, for cells that we don't want in the body. That's what my A&P professor was working on. On that at Berkeley.
Wow, that's great. That's
good
to know. Yeah. Thank you. Yeah. There's a lot of research, cutting edge research going in that, kind of the direction that area. It's very interesting, to see how far they, got with, with life expectancy, and it helps to some extent, the neoplasm cancers, patients with, people with cancer. So the genes and genetic, that will bring us to genes and genetic disease, because we try to get to genetics, and then I'm not going to spend much time on genetics because that's very basic stuff from other courses. But I would like to spend some time talking about the fluid electrolyte and ABGs. If not, we don't have enough time, then we'll do that on Friday. Any questions before we get into the genetics and genes and genetic diseases? Any questions? So genes and genetic diseases, and again, this is very basic stuff from from other courses. I'm sure they covered this. And before we get into yeah, it's here. Why to study genetics? What do you think we as nurses we need to know about this stuff? Yeah, I recall, like, maybe like 15 years ago when I used to, this is my 25th year of teaching. I don't think we used to, like, briefly go over this very fast within like 2-3 slides, and very minimal. But now we extensively, like this morning, I spent 2 hours, 1 hour 45 minutes, I would say, with adult health 2, just talking about the genetics, genomics. There is too many reasons why we should integrate this in our curriculum, especially the last 5, 6, 7 years. What do you think the significance of this?
To prevent disease.
So we have to understand genetic science to aid patients in therapeutic modalities. But this takes us to the genetic testing too, right? Not just to understand genetics, but also there is also in the science, which is genetic testing. So if we don't understand, or we know extensively, we go over the science of genetics and genomics, won't be able to educate the patients about the science, first of all, about the principle and concepts of genetics and genomics. And also they need there's always an answer questions about genetic testing. And patients always have questions about, the test, the results, how to explain the results, and about what's next, follow up. Should I be doing this testing or undergo this testing or not? What do you think, about the treatment, which route to take, or which? So what's your take on this? What do you think? You have any reflections on that about the genetic testing? Why it's significant for nurses?
I think genetic testing is important, like in general, because it just helps people with prevention. Because if you understand like what traits are involved in your genes, then it's easier for you to like protect yourself. Like, you wouldn't want to have children a certain way because you know that so and so is involved in your genes. And it's important for nurses to know too, so that they can educate people on the steps that they might want to take in the future. Because if you don't understand, like, for example, like sickle cell, if you don't understand the dynamics of sickle cell, then you can't really teach anybody about the importance of not wanting to maybe have a child with somebody who also has sickle cell.
Oh, good. Perfect. What, anyone else or anybody else?
Nowadays, I think they make medication according to your genes, that matches your genes.
Mm-hmm. But what about the testing? If the test's going to reveal some genetic makeup and information that's going to be subject to others to misuse it, who would be at risk for this?
To misuse it?
Yeah, to be misused, yes.
Ooh.
Let's say that you are going to be tested genetically for a genetic test for, let's say, breast cancer, and found that, this, because the BRCA1, BRCA2, it's high penetrant and has 60 to 80% penetrance rate. So that at least will give others that you have a risk to develop the disease. You may not, but there is a risk that you may develop this in the future. Who would misuse this information if they have access to it?
The patient.
Yes.
Insurance companies.
Right. Pharmaceutical. Not much. They will be happy, right? Pharmaceutical, because they will, they won't sell more drugs for those people who would like to take any type of drug for prophylactically. But in this case, then this scenario would be prophylactic mastectomies. Some, females has gone that route, which is, prophylactic mastectomies, because they have been tested and, they found that, they have a high risk and family members have it. And they just, they found that there is, the risk is high. So that's, they will go that route. So the health care, the health insurance companies could, misuse it. in terms of discriminate people between, like in terms of either they will increase the premiums or they can deny your coverage. They can do a lot of things. They can do employment or workplace employers. They can use it. So we will talk about more, more about this in adult health too, and its relevance to the practice and nursing practice, because it has a lot to do with what is called the Genetic Information Protection Act, which was enacted or passed by the Senate in 2008. And we are now protected by this act. Nobody can misuse this information. Healthcare insurance, health insurances or employers or even researchers, because sometimes you'll be in these genetic tests are very expensive, and if you consent that you want to be part of the of the research study, you as a participant, they sometimes give you an incentive. Okay, well, we'll approve you to the cost of, and give you the cost of the genetic test, and it's very expensive. It goes up to thousands of of dollars for just one test. So they will approve it for it to cover your test cost, the cost of the test, and in order to be a participant, agree, you consent, and then who would protect that the result of these tests is going to be confidential. Confidentiality, HIPAA would cover it, but dissemination and sharing these results with other entities, who would protect it? So the GENE Act would cover that piece, but again, in every single billing or bill or a law, or there's always loopholes. Always they will find easily kind of loopholes to go around the system. So, but we have an umbrella, we have a general kind of protection by the GENE Act, which is Genetic Information Protection Act. Again, this is 2008, doesn't mean it's too old. It's fairly recent. It's like 10 years or 12 years ago. So but at that time, when we started to infuse more and integrate more of the genetic genomic G/G, we call it genetics genomic science, and now even the state board mandates that all nurses supposed and healthcare providers supposed to have at least one CEO of G/G as part of their a workshop or some form of knowledge base. So it's a requirement. So the genetic genomic science, it has a lot of implications when it comes to nursing practice, and we'll go more intensive and comprehensive, more wide, in a broader application in adult health too. So the genetic, again, most of this very basic. I'm not going to repeat. I'm sure most of this from other courses, the chromosomes and the abnormalities of chromosomes and autosomes versus the sex chromosomes, the mutations. Is this first time you hear about the mutations? I believe that you covered this in in biology, right? Yeah, the different types of genes. Some of the genes are now each gene supposed to provide like a recipe for the cell. Specific gene is responsible for one protein synthesis. So let's say that the protein here, it can be enzyme, can be any chemical in our body. Let's say that it's an insulin. Now, some of the genes are, so the gene responsible for the insulin, for production of insulin, synthesis of insulin, is present in the cells of the beta of Langerhans. So the beta cells in the pancreas responsible for production, right? So the gene in these cells of the beta of Langerhans in the pancreas supposed to give orders for the genes supposed to give orders for these cells to produce the insulin. So the genes in the pancreas is turned on. These cells, specific cells, they are turned on. So they're supposed to be expressed or turned on genes in order to be actively or able to synthesize the protein. In this case, it's the insulin. I'm giving this example because there are also genes in the skin cells that are able to produce insulin, but the gene is turned off. So in other words, it's not expressed gene, so it's not going to produce any insulin, the skin cells. The only cells to produce the insulin or able to produce the insulin is the cells in the pancreas. So this is an example of turned on and turned off or expressed gene. Turned on means expressed gene, turned off and expressed gene. So each gene is supposed to give orders to the cell, what type of gene to produce or synthesize, how much of that gene should be produced. Let's say insulin, how to produce the insulin from different ingredients. In this case, all proteins composed of amino acids. And how to make it, the recipe. The gene is supposed to tell also the cell how much to produce, when to stop. So all the specifics, so that's why we have controlled production of every chemical or hormone or enzyme. Now, when there's mutations, which is in other words, there's an alteration of the gene structure or the activity of the gene has changed, then we have mutation. So it can be at the gene level, can be at chromosome level. So we have the gene locus, which is the exact location of the gene on the chromosome, is called locus. For example, here we have the gene responsible for the blood group or type is located on chromosome number 9. And this is just a difference between the DNA and RNA. I'm sure you know this from biology. Genes, or the analogy you can use for the DNA, chromosome, and genes. DNA is like a cookbook, and the chromosome pairs like the chapters in the book, and then the genes, the individual different recipes contained within the chapters. That's just what an analogy has been used in other, like in mid-search textbooks about the DNA, chromosomes, and genes, and protein synthesis, transcription, translation. We will explain this more in depth during the pathophysiology of the HIV/AIDS disease. That will be very, well explained and make sense when we discuss or explain the pathophysiology of HIV/AIDS, transcription and translation. Transcription takes place within the nucleus when the RNA the DNA tries to make a copy of in the nucleus, and that's when the RNA messenger enters the nucleus. So the messenger tries to make copies of the DNA, which is usually located, 99% of the DNA is present in the nucleus. So when the messenger RNA enters the nucleus, it tries to make copies of that, copy the genetic material, which is mostly DNA, and then it will exit. And that all of this is called transcription. When it exits the nucleus, it's called translation, and trying to make copies of that outside. So that will take place in the cytoplasm outside the nucleus, and that is called translation. And I will go over this in when we explain the pathophysiology of the HIV/AIDS. Deletions, duplications, also examples of deletions, like babies are born with Creutzfeldt, which is deletion type of a genetic disease. Duplication when there is an excess. An example of duplication would be the trisomy 21, which is the Down syndrome, because in Down syndrome there is an extra chromosome at number 21. Chromosome 21, it doesn't have two. The chromosome supposed to have a pair of chromosomes, but that for patients with Down syndrome or trisomy, because they have 3 chromosomes at number 21. We call it trisomy 21, right? Or Down syndrome. The inheritance or patterns of inheritance, we have autosomal dominant disorders, recessive, and sex-linked or X-linked. The dominant, like in the HD, for example, look at the HD, the affected parent and normal parent, because the diseased allele. So we have to, if you know, each parent should have two alleles, one recessive, one parent has dominant, which is the diseased one, right? So it's the dominant, just the uppercase A, which is the diseased one, and then recessive, which is the lowercase a. Now, the affected, only one affected parent married to a normal parent, because this is a dominant, autosomal dominant, then it's all it's prediction. It's predict the percentage of affected versus the healthy and the carriers. In this case, there is no carriers, either affected or normal, or healthy. So which goes to a 50% affected and 50% healthy. See that the significance of this kind of inheritance is that there is no way to evade or to get away with the disease, because it's going to be present in every single generation. And that's the danger and significance of this inheritance, is it going to be present in every single generation, given it's affecting the autosomal dominant, the dominant allele. For recessive, if we look at recessive, we have a less significance in terms of that it's a recessive allele that is unhealthy or diseased one, and the 25% of the offspring will be healthy, 25% affected, and then 50% carriers. The X-linked recessive, who would be more protected, males or females?
Females.
Females. See how is because of the two X's, normal daughter here, two X's, right? So there's you can think about, this as the additional X is going to be protecting the female. So that's in X-linked recessive inheritance, that's going to be affecting more males than females. So it depends on the scenario. You have to run the the chart and see the connections to find out. It depends if the carrier both, only one, and then you have to run it to find out the results. And mostly would be carriers, like 25% affected son here. It's 25%, and then 25% normal daughter and 25% normal son. This is a different scenario of the recessive, the X recessive. Pedigree, think that you covered this in 235, right? Physical assessment, yes, no? Pedigree, and the symbols for pedigree, how to read it, and it has to be like 3 generations, right? To be meaningful and done correctly, supposed to be covering 3 generations. And then the multifactorial inherited conditions, these are the conditions or health diseases, the diseases or disorders that involves more than just the genetic predisposition. You can add to that also the environmental and maternal factors. Even when we discuss the autoimmune disease or diabetes or hypertension, Alzheimer's, all of these are cannot be discussed without considering the environmental factors or the maternal factors, in addition to the genetic as well. So that's why we call it multifactorial inherited conditions. And here are some of the examples of the chromosomes or the inherited. The multifactorial inherited diseases, like for example, the patients with sickle cell anemia or with hemophilia, with Marfan syndrome. These are chromosome defects. On the other side, we have teratogenes, which is some of the factors could result in that the baby is born with with these defects, like toxoplasmosis, which is usually who is affected by this. Babies are born, or I mean, most of the time it's a stillbirth, or babies are we call it stillbirth, which is dead fetus due to toxoplasmosis would be more affected by this. When pregnant women are close to or in contact with
It's a cat.
cats. Yeah, the cat feces, they have a bacteria called toxoplasmosis, and very dangerous and fatal lethal to the development of the fetus and could result in the death of the fetus. So that's some, called some of the infections are very dangerous. In addition to the other factors like maternal disease could also result in like diabetes, having large babies, for example. Examples of genetic. So I think we reaching the the end of this lecture. So let's stop